That's good. So I was asked to talk on HER2 positive disease neoadjuvant therapy and how we do the multidisciplinary discussions around the patients. Here are my disclosures. And I would like to talk about the current standards, neoadjuvant approaches, what chemotherapy to use, what do we do with the adjuvant therapy, and what the guidelines say, and then maybe hint at future developments as well. So with the early breast cancer management, this is an article I wrote with Dr. Cardoso and a number of international colleagues. It's very structured. You have the luminals. You have on the left side, you have the triple negatives, and you have the HER2 positives. And in our country, we do treat the triple negative and HER2 positive disease mostly in the neoadjuvant fashion. And we have some good results with our patients who accept this very well, because they do understand that we can sort of take away therapy or add therapy depending on the result. Before we go on to the neoadjuvant approach, I would just like to point out that there is this small pocket of patients with a small node-negative tumor where we have this very good evidence from our American colleagues that 12 weeks of paclitaxel weekly plus 1 year of trastuzumab is sufficient. And here's the data, the 7-year data from Sarah Tolaney, which is now also published, and the original publication was in the New England Journal. And you see that there's only 1% distant recurrences after 7 years. So I don't think we have to argue that there is more high risk and more low risk in this population. We would treat the patients just like the Tolaney regimen says, don't do neoadjuvant, don't do dual blockade. And so I will talk about other patients in the rest of my talk that have intermediate and high risk HER2 positive early breast cancer. And if you look on the very right side, sometimes if you have this patient with 2 centimeter or 1.5 centimeter tumor node negative, you take her to surgery, you do the sentinel with the blue dye, which I just learned, and you find out that she actually does have positive nodes. Then the APHINITY data very nicely shows that you can give this patient chemotherapy in the adjuvant setting and 1 year of dual blockade if that's available. And you can actually also produce some very good results. So, but for the remainder of the patients with more than 2 centimeter tumors or node positive, I would definitely recommend to take down this neoadjuvant approach. In our guidelines, and you can see the guidelines, they're free of charge. You can download them in the web. There's an app for the smartphone, also free of charge. And the German guidelines just give you the level of evidence, because we don't believe in like these cooking recipes, what to do with an individual patient. You just need to know the evidence, and then you have to make up your mind depending on what the patient wants, her family wants, what she can pay for, and so forth. So it's always good to have a lot of flexibility. It's not just the operability, but it's also that we can actually improve patient outcome by individualizing post-neoadjuvant therapy. I think there's enough data now that to show this. So as my colleague who gave the talk before me nicely showed, we need this multidisciplinary team, and we need to sort of take everything together and then come up with a treatment recommendation. So the early data on neoadjuvant therapy comes from the FDA meta-analysis, which actually consisted, half of those patients came from the German GBG trials. And you can see here that in HER2 positive disease, there is a strong impact of PCR, which is the upper blue line. But if you don't achieve a PCR in the hormone receptor positive situation, for example, you still have a good outcome. Only in the hormone receptor negative HER2 positive situation, if you don't receive a PCR, you really have a problem. And we can now overcome this, we know very well, with TDM1 as a post-neoadjuvant therapy. We also learned that there is a differential response rate, and PCR rates are much higher with hormone receptor negative HER2 positive disease. the original trial that sort of established the dual blockade with trastuzumab and pertuzumab was the Neosphere trial by Luca Gianni and his colleagues. And you can see here that the dual blockade with the taxane just almost doubled the PCR rates. And ever since there was an approval and this regimen has been taken forward. All of these patients in the Italian study did get anthracyclines after surgery. So this was just the pre-surgical therapy. We have now multiple studies looking at PCR rates in neoadjuvant therapy with anti-HER2 therapy, and you can see that the PCR range around 50 to 60%, so are quite high now, independent of what regimen you use. And the Trifina study, which was actually meant to show cardiac safety of trastuzumab and pertuzumab, also gave us some very good idea about what we can reach with an anthracycline-containing component. On the two left sides, you can see FEC followed by taxane with dual blockade, one with the dual blockade already with the anthracycline, the other one just with the taxane. And on the right-hand side, you can see the TCHP regimen, which was developed by Dennis Slayman in California and now is very widely used around the world. At ASCO this year, we had some data from the Dutch TRAIN2 study. They used a strange regimen, which probably you have not used so far, with paclitaxel weekly, carboplatin every 3 weeks, and pertuzumab and trastuzumab compared to the same taxane platinum backbone together with an anthracycline 3 cycles of FEC. The study had about 438 patients, and the primary endpoint was reported some years ago at ASCO already and published in the Lancet of Oncology. And you see that the PCR rates do not differ whether there was an anthracycline as a chemotherapy component or just taxane and platinum. And this was also true for larger tumors, smaller tumors, node negative, node positive, no difference in PCR. At that time, I looked at the data and said, well, this is a strange regimen. We wouldn't use that. So I wasn't so interested in data. But when this year asked the outcome, I suddenly became very interested because, as you can see here, there is no difference in outcome whether you use an anthracycline in HER2 positive disease as neoadjuvant component or just the taxane and platinum. And there was no difference in young women, older women, node positive, node negative, no single subgroup where the anthracycline was actually better. And what we also saw was there was a lot of cardiac toxicity or suspected cardiac toxicity. If you just count the LVEF decrease, this is not necessarily clinically meaningful cardiac toxicity, but you can see there's a lot of heart changes, and some of these patients did not recover. And also there were 2 acute leukemia cases, 1%, and the investigators deemed them chemotherapy associated in the FEC arm. So with all of that, we changed completely our standard after ASCO this year, and we do not give anthracyclines anymore in HER2 positive early breast cancer. And I'm following basically Sarah Hurwitz, who said in a wonderful discussion at this year's ASCO, it's becoming hard to justify routine use of anthracycline-based therapy for HER2 positive disease because we do not have superiority with regard to efficacy. We have more cardiac toxicity. And this is not the only study. We have the BCIRG-06 study, and we have other studies without anthracycline. So there's a number of studies showing that probably it's the interaction with the taxane and a little bit of chemo in HER2 positive disease, but not all that chemo that we used to give earlier. So let's go back to our Neosphere trial. As I said, they got docetaxel, Herceptin and pertuzumab, and then anthracyclines after surgery. And you can see that patients with the dual blockade do well. They do better than patients with a single blockade. And you can also see that PCR patients do better than no PCR patients. But still, even the best group, there is still only 86% PFS at 5 years. So there is always room for improvement. So let's look at what we can do for those patients who don't have a PCR. The CATHERINE trial was a very simple trial, very pragmatic. A lot of patients fell into the CATHERINE criteria. The tumor had to be over a centimeter, and just the very, very small node-negative tumors, initially node-negative tumors, were excluded. And then patients had to have 9 weeks of trastuzumab, 9 weeks of taxane, but 6 cycles of chemotherapy. I think that is important. And then about 2/3 of the patients had positive hormone receptors, about 1/3 hormone receptor negative HER2 positive tumors, and only 20% had dual HER2 blockade in the preoperative setting. I still remember the times we also had patients in the CATHERINE trial. Those were times when the dual blockade was not registered in Germany, and we also, our patients paid for the 4 cycles themselves. When you look at the characteristics upon surgery before randomization, you see that there's about 20% of the patients that have very small residuals, less than a centimeter after the neoadjuvant phase. So the data we're now going to see will also apply to large residual tumors, patients who didn't respond at all, but also to these very small ones, because in our tumor board, we always have the discussion, oh, this is just a 5 millimeter lesion. We really need to give TDM1. If you want to follow the CATHERINE data and you can afford the medication or it's registered, then you have to follow it, because the data also applies to those small tumors. Here, the efficacy data, you've seen them probably many times before. There was a stunning reduction of invasive disease-free survival events with a hazard ratio of 0.5, highly statistically and clinically significant, and an 11% difference in invasive disease-free survival at 3 years. We can also say there is still, I mean, full or half empty. You can also say there's also room for improvement. We have to do something better for those patients, but at least the TDM1 helped them a lot, but it's not optimal. We still can improve on that, and there's trials going on trying to do that right now. If you look at the recurrences, you can see that mostly distant recurrences were prevented. And so it's actually those recurrences that the patients will die from eventually. And the one thing you see, the CNS recurrences were not prevented. So the TDM1 in a brain where there is no disruption of the blood-brain barrier cannot prevent, apparently, CNS recurrences. And what you also see, and this is going to happen over the next 10 years, is that we have less metastatic HER2 positive patients or tumors, but those who will recur, half of them already have CNS metastasis. So we see a shift towards more aggressive disease in the metastatic setting in those patients that do recur after these modern therapies. Let's look a little bit at some of the clinical important issues for the tumor board discussions. So if you look at HER2 hormone receptor positive versus hormone receptor negative disease, there is a similar impact of TDM1. And for those of you who remember our ADAPT trial, which I just presented at ESMO with the 5-year survival data, we did not see an impact of endocrine therapy on efficacy of TDM1. So apparently TDM1 works independent of whether you combine it with endocrine therapy or not. So this is a very good data set, because we can give adjuvant endocrine therapy to those women. Then the question always comes with the radiotherapist, can we continue these medications while patients undergo local radiotherapy? And we put a slide in our data set from the guidelines, because this is always something we ask in the tumor boards. So there is very good evidence that you can combine either trastuzumab, pertuzumab, or T-DM1 with radiotherapy. There is no harm done. The data shows that very clearly. If your radiotherapist is a bit worried, I think in practical terms, it's not a big difference. Then you just maybe give the antibodies 1 week later, because the radiotherapy has now gotten much faster than it used to be because of the hypofractionation. And here you can see the data, the IDFS benefit with regard to radiotherapy, and you see also T-DM1 works independently of whether the patients get radiotherapy or not, and it's with the same hazard rate as in the whole trial. The last thing, which is always important, because there's a lot of discussion always at the tumor boards, if you do an IHC analysis of the non-PCR specimen, like look at the non-PCR, look at ER, PR, and HER2, does that impact your decision for T-DM1? There is a small group in the Catherine trial where they could evaluate that. They had 70 patients where the HER2 status became negative in the non-PCR specimen, and those patients did respond well to T-DM1, and there's no event in the T-DM1 group, and there's already 11 events in the trastuzumab group. So the data we have shows that the T-DM1 efficacy is independent of the non-PCR HER2 status. There can be many reasons for that. The non-PCR specimen is the resistant disease. There may be tumor heterogeneity, but you cannot know whether the disseminated tumor cells that are actually going to kill the patient eventually, whether they also lost their HER2 status. So we do routinely immunohistochemistry in the non-PCR specimen just as a quality control and to see whether there's tumor heterogeneity, and we do offer T-DM1 also to the patients where the tumor is HER2 negative in the non-PCR specimen. Let's look at tolerability. The tolerability was actually very good of T-DM1. We know that there is some liver enzyme changes, low platelets, but nothing worrisome. There is some increased neuropathy, probably because of the taxane pretreatment. We have some patients where we have to dose reduce. If the patient doesn't tolerate it at all, you can always go back to the antibodies without the chemotherapy, like trastuzumab, pertuzumab. So we just have to ask the patients with regard to neuropathy. And I think it's very, very important to prevent neuropathy by already counseling the patients well during the taxane chemotherapy. Let's just look at the other side of the coin, what to do in case of PCR. Are these patients cured? Do we need to do anything else? So we know from the Neosphere trial that there is still also a relapse risk in patients with PCR. They had less relapse risk than those with non-PCR, but still, not 100% of these patients were cured. And there's some very nice data by my colleagues from the German breast group, which was presented 2 years ago, where they looked at all the neoadjuvant trials and asked the question, who has a risk of recurrence after neoadjuvant therapy? And it's mostly like my surgical colleague before described, these large tumors that's also high nodal burden that do achieve a PR, but still there is some residual risk. So what do we do then? We do have good data from the APHINITY trial, which tested dual HER2 blockade with trastuzumab, pertuzumab versus trastuzumab, that actually patients with node-positive disease do benefit from 1 year of dual blockade. Node-negative disease patients don't benefit. So in our clinical setting, we don't give dual blockade outside of the neoadjuvant setting to patients with node-negative disease, but we do offer it to patients who were originally node-positive, even after PCR, to complete their 1 year of dual HER2 blockade instead of just 1 year of trastuzumab. The hormone receptor status does not make an impact on your decision versus dual blockade. You can see here that both hormone receptor positive and hormone receptor negative patients do benefit from dual HER2 blockade. So with regard to this post-neoadjuvant therapy, this also what I've just told you is in concordance with our German guidelines. As you can see, in low-risk disease, in case of PCR, we only recommend trastuzumab. In node-positive patients who were clinically node-positive before starting neoadjuvant therapy, we do recommend to continue the 1 year with the dual HER2 blockade. In non-PCR patient, we switched to TDM1, and we've written off-label applications in the year before the registration because the data is so convincing that I think this is something we just need to offer to our patients. And as you all know, there's also data from the Extenet trial looking at neratinib after 1 year of trastuzumab therapy. Actually, those patients had a 5% absolute difference at 5 years, favoring neratinib. So we do talk to patients about this option if they have high risk, like node positive non-PCR disease. And here you can see the algorithm I showed you in the beginning again, which nicely states all the options. And I just wanted to highlight that after ASCO, we should think about omitting anthracyclines. And TDM1 remains the standard in non-PCR patients, even if the non-PCR histology reveals HER2 negative disease. So just a summary, and then I'm looking forward to the discussion. So neoadjuvant therapy has become the standard because of the favorable correlation with outcome if you have a PCR. If you have a non-PCR, we do have an option to escalate therapy. The risk-adapted interdisciplinary management is essential. So the tumor boards where we look at this, the tumor before and after therapy, we clip the tumor. In our guidelines, it's also recommended to biopsy the axilla to histologically verify that there is nodal involvement. The radiotherapists want that information. Then the chemotherapy standards, the anthracycline, I still have in there. I think we need to think about getting rid of the anthracyclines because of the data I just showed you. But if you don't have all the anti-HER2 medications available, your choice may be a little bit different. The dual HER2 blockade is standard in the neoadjuvant setting and the adjuvant setting if there is a node-positive disease. And just these low-risk patients, up to 2 centimeter node-negative, 12 weeks of paclitaxel with trastuzumab for 1 year is sufficient. And 1 year of anti-HER2 therapy would be the standard. And the individualizing concepts that are now being done all over the world look into early response and PCR status and try to de-escalate chemotherapy. And I just, I know that maybe in your country, not everybody has the resources to afford all of these drugs, but I still think the neoadjuvant approach is a very important approach if you don't have all the resources, because if you see that the patient has a wonderful response to what you've done in the neoadjuvant setting, it's much easier to tell her if you can't afford, you can stop your antibodies or whatever early. But if the patient did not achieve a PCR, I think you will try everything possible to escalate the therapy and make sure that she has a decent chance for cure. Just an interesting note at the end. In the COVID-19 pandemic, we were forced sort of to cut down on face-to-face visits in our center. So we use an e-health module. It's called Concedo. You can try it out. It works also in your country. It's available in different languages, English, also probably not your local languages, but all the major languages like Arabic, Spanish, French, whatever. and it records the drug intake, it records the well-being. If the patient is feeling well, there's no more questionnaires. If the patient is not feeling well, she gets more questionnaires. There is an interactive system programmed into the eHealth application, and we have also a feature for COVID-19, so they can take their temperature and whatever and record it. So this has helped us tremendously in patients that were not able to come to the center. So we were just alerted if they were not feeling so well. And I think unfortunately, we have to get used to these things because the pandemic will still probably stay here for a little while. So with that, I would like to close and thank you all very much for your attention. And I'm happy to take any questions. Thank you.